Hello everyone. So let's come to implants and prosthodontics. Coming up to the most advanced option that a prosthodontist have or any dentist for today has to replace any missing structure is implants. So what exactly is an implant and how old is the concepts of implant? What are the different types of implant that we have? We will all come across. So definition of an implant, it's a graft or any foreign object which is inserted firmly or deeply onto the alveolar process that may be prepared for the insertion of the tooth or teeth per se. So a dental implant will be a substance that is placed into that of the oral cavity jaw to support a crown or a fixed partial denture or even for that matter removable partial dentures. So now first important thing is that what is the difference between a natural teeth and that of a tooth. Natural teeth tooth as well as, now let's see what's the first and foremost important thing, the difference between a natural teeth and that of an implant teeth. So a natural tooth will have periodontal support. It will have the compressibility, whereas that of the implant will not have a periodontal support coming over. It will have rather a connection of osseous, that is a bone, to that of the implant with the help of surface modification. We will all come in forward lectures in that. Also, implant's compressibility is very less rather than that of a natural teeth. A natural teeth can be compressed to 25 microns, whereas an implant can be only compressed to 0.5 microns. So hence, we cannot even think of connecting a natural teeth to that of the implant. So there are different theories even after that. So other things which are important and different in case of a natural teeth and that of implant is, our natural teeth do have a special receptor that is called a proprioception that is present in that of the natural teeth, whereas an implant lacks that kind of receptor. Hence, we need to design the implant and keep it little infra-occluded for that around 30 micrometers so that this proprioception acts when there is some hard particles or stone particles into that of our bullous. So what are the indications for implant? Can implant be placed anywhere? Can implant be placed anyhow? Implant should be tube driven, implant should be area driven, or implant should be prosthetically driven. So the latest concepts according to the psychology and the scientists coming over the studies are implant should be placed prosthodontically driven, where our prosthesis is gonna come. Doesn't matter if the bone is present in that area or the bone is not present. If the bone in that particular area is lacking, do a bone graft, do other procedures to increase the stability of the implant, but do not make your implant to that place where you have bone and not prosthodontically driven. Second important thing is the quality and the quantity of the bone present. Every bone has its quality depending and classified according to D1, D2, D3 and D4. That is, it has got dense porous bone, it has got cortical bone, it has got weak porous bone, that is a complex bones present. So based on that also our implant placement will be different. Also our implant placement will be based on the number of edentulous space and number of teeth that we are supposed to replace. We cannot put a cantilever of the last teeth onto one implant. We cannot connect an implant to that of the natural teeth. So these are all the indications that we need to go. A patient who is medically compromised may supposed to be an osteoporosis patient, a diabetic mellitus patient. All these patients who are not medically fit to go ahead with any surgery is also not fit to proceed for implant placement. More likely, a patient with the bone disorders like vitamin D deficiencies or also bisphosphonate deficiencies are also prone to less success rate for implants. So these are all the implants you can see. See, that's a removable partial denture fit on to 4 to 6 implant based on the study where it is in maxilla or in mandible. Coming to this is a fixed partial denture. We can see 2 implants connected with a fixed partial denture bridge. That is the different. And what is an advantage of using an implant? So the first and foremost advantage of using an implant is preservation of bone. So preservation of bone. See, for example, a tree and there is some sand and soil behind the tree. So beneath the tree there is some soil. So once there is a rain, the soil amount will be taken over, will wash off. But if the tree wasn't there, the amount of soil that will wash over will be more. Similarly, imagine our teeth to be present. When our teeth is there or a bone is there, so the teeth and the bone resorption rate will be less where there is teeth present because of the bundle bone. Teeth is when extracted, the resorption rate will also start increasing. Similarly is when we place an implant. So implant, when we will place, the bundle bone is preserved, and that is how the resorption rate will decrease. The function and the aesthetic per se, function of implant when we are using is very high in function because it can take up the load, the masticatory load of a pontic for a fixed partial bridge. First and important thing, disadvantage of fixed partial denture is two natural teeth that we are compromising to replace one teeth. Whereas for an implant, we are not compromising anything. We're just placing an implant to the individual place where the tooth was to be replaced. Similarly, coming to the aesthetic purpose, an implant's aesthetic is governed by just like a natural teeth. Because we have the soft tissue curvatures which will be formed with the gingival former, then we'll see how is it. And comfort of the patient, of course, and that is the best treatment possible. See, we can now find out from this picture which all teeth is implant. Just because I have placed, we can see that this is an implant, this is an implant, this are the teeth which are implant supported, whereas this one is not, which is implant supported. Coming to the disadvantages of implants. Now, what are the disadvantages of implants? The first disadvantage is vitamin M deficiency. Vitamin M, that is a patient's money problem. That is, if the patient is not economically sound, he cannot be affording an implant. So that is the first and foremost thing. Second, prosthodontically driven implant is good to say. But if the bone is at all not present, how will we hang out a bone in that place? And where there is bone, if there is no occlusion required in that particular place, why will we place an implant? Thirdly, the quality of the bone and the quantity of the bone present is almost nil down there. So if it is a flat ridge, then augmentation is one procedure. If the patient is not willing for the procedure, again there is no implant possible. So those are all the contraindications. And the most important disadvantage is again the vitamin T. That is a time factor, that it takes about time for an implant to be placed and then wait for 4 to 6 months based on which arch you are placing, and the placement requires a wait of around 6 months for the final prosthesis to be coming over. So these are all the disadvantages of implants. And also, if the implant diagnosis and treatment planning is not done properly, what are the diseases that the patient can face? Peri-implantitis, an infection around the implant, all the bone is lost. There can be recession of the gingiva in that particular place. There can be some problem with the incisal overlook, that is, the metal collar can be seen. If you have not justified the biotype of the gingiva, then the metal collar will be seen. If we have not followed the papilla law, then if the papilla is receded down, we will find out the black triangles between the incisal. And also sometimes there can be fracture of an implant and abutment screw, which is most commonly seen. Why is the fracture so? Because to place any screw within the implant, you need some torque. The torque should not be more than 30. So if the torque increases more than 30, you are destroying the threads of the screw. The screw is made up of gold and titanium, the very small and delicate screws. So those threads will be compromised and then there will be fracture. Fracture of the abutment itself, if the size of the abutment to that of the implant is not good and the crown implant ratio is not maintained, and then there will be of course a fracture. If there is a cantilever or an offset load on the incisal edge, there will be of course a fracture. There can be fracture of the abutment. Peri-implantitis due to dental cements that you have placed. Loss of, if the dental cement is being more over there and you have not cleaned it up before final cementation and setting of the luting cement, then it can lead to full decrease in the bone quantity. You can see this was all, and there is full amount of implant which is exposed in this particular section. You can see the implant itself is exposed due to the cement which was not cleared by the dentist. Classification of implants. Now there can be different types of implant. Now based on what are the classifications, so based on the material it can be, based on where they are supposed to place in the tissue, the implants has to be classified. It is based on the reaction with the bone, the implants are supposed to be classified. Now based on the tissue placement, it can be endosteal, it can be perosteal, it can be transosteal, subperiosteal. Name is all saying about it, subperiosteal. So that is beneath the periosteum, we can see here. So metal framework lies on the top of the jawbone and the lower jawbone, and this is the mandible. There is this gum tissue which covers the implant framework. Then transosteal, from one end to the other end, transversely present. So it is bicortical type of implant. Now it is in picture, this was an earlier picture. Now bicortical implant is very good. Why is bicortical implant good? Because of its stability. Because both the sides is getting to cortex. Now coming to endosseous implants. Endosseous implant is any implant which is into the bone in the halfway. Now those can be the older times which was used before 80s. Those are called plate form implant. You can see the picture over here. These are the blade form implants which were used in earlier 80s. And now this is obsoleted because of the hampering of the implant bone that we are present over there. We are cutting over more bone. So that was not indicated, and nowadays we are not into practice. Nowadays the implant there is screw form or root form implant. Like our root is there, like it has got upper to lower curvature, upper to lower tapering, all those root form implant is one which is come into picture. Now based on the different materials that we have, now those materials based on also it can be classified. So what are the different classification based on the material? So it can be metallic implants. Metallic implants, it can be made of titanium, it can be made of cobalt chromium, or it can also be made of molybdenum. It can be ceramic implants. Nowadays there is a ceramic implant. What is the importance of ceramic implant over a metallic implant? At times when this implant itself is protruding any color outside, a metal will display a black color. When we are planning for a all ceramic or a zirconia crown, we want that no metal blackish color to be coming out, because it will not have any champagne effect on that or a camouflaging effect on that. So in that case, ceramic implants are supposed to be used in those particular patients. Depending on the reaction with the bone, it can be bioactive, it can be bio-inert implants like hydroxyapatite crystals. It has found that if you add these in the surfaces of implant, it is gonna give more effect to the implant per se. Whereas in a bio-inert material, those will not cause any disadvantage by placing in the human body. Those are bio-inert materials, that are the titanium implants or the gold implants, which are biocompatible in nature. So all this different kinds of surface modification, why is it done? So that the bone and the implant gets mixed together. Now this procedure of understanding a bone and an implant getting mixed together is called osseointegration. That is, osseo means bone. So integration of the implant with the bone. Two theories, two big scientists came up with their theories. One is called the Weiss theory of fibro-osseous integration, and one is called the Brenmark's theory for osseointegration. Brenmark said that the bone itself is gonna interlink with that of the implant body and the surface texture, whereas we said no, there is a fibrous cartilage connection between the bone and that of the implant. So there were different theories which came up with these two, supporting these two main theories. So osseous integration, which came up in the year of 1993, recently said that there is a direct attachment or connection between that of the osseous part of the bone with that of the implant superstructure, which is either with the hydroxyapatite or without, but most important thing was it didn't have any connective tissue along with it. So that was the main subject of osseointegration. Whereas so what we say, it is an interface of the alloplastic material with that of the bone. GPT made it very easy that it is an alloplastic material bone interaction without a connective tissue. Whereas what was the fibro-osseous integration? It said connective tissue played an important role in joining both the bone and the alloplastic material, that is our implants. Now, what are the factors that will affect the osseointegration? Of course, anything when hurt and you put more pressure, the healing time increases. Similarly, the occlusal load that you will put on the implant will decide how much time will it take to integrate. Second important thing is the planning of the implant that you are going to do. That is, where you are putting an implant, if it is an anterior implant or it's a posterior implant. Because in a posterior implant, the bone that we have is D3 or D4. Whereas that in anterior mandibular implants, we have D1 bone. So that has more capacity to integrate faster rate. Whereas the bone which is porous, like maxillary posterior region, it will take more time to integrate. Similarly, the implant bed that you have created, that is a surgical bed. Surgical bed that you have created, if you have not created enough blood supply in that and you have destroyed some amount of blood supply down there, so again what will happen? The natural healing process will be delayed, granulation, tissue formation will not be there, and the different stages of healing will not occur. Hence, the osseointegration will be delayed. Even if there is a surgical technique is mattering. How is the surgical technique mattering the implant osseointegration? Surgical technique, because how much torque you have used to place an implant, how much heat have you generated while placing the implant, how much revolution per minute RPM that you have used to place an implant. These are all the facts that also governs the osseointegration of an implant. Also, one important fact not mentioned but yes is about the topography of the implant, that is whether the implant is an active implant or a passive implant. Now, what is the difference between active and a passive implant? Active, which has already got big threads, so it has more surface and surface area, force upon surface area, that will increase, so the integration will increase. So more surface area, more integration faster. So this is how osseointegration it is affected. V's theory of fibrous integration, we already discussed that there is a connective tissue lining which is coming over between the bone and that of the implant body, which was discarded and not followed much. Coming to the parts of implant that we have. Now, the parts of implant is, the first part is implant body, the implant itself. Also, it is known as fixture. It has a healing cap which has to be placed after the first stage of surgery. Now, after placement of the healing cap, why do we place healing cap? The name itself is saying healing cap. What is it healing? It is healing the soft tissue, the gingival biotype present over there. So, based on the gingival biotype and the size of the gingiva, we are supposed to decide the healing cap size. Also, one more factor that will decide its size is the which teeth is supposed to come, because that is what is going to give the collar, the aesthetic collar appearance of the teeth. So now these are the abutments on which the implant crowns will be placed. Now impression post, while placing and making the impression, prosthodontic requirements are that you have to have the abutment analog. So this is nothing but an abutment analog, the impression post. Impression post, this is an placed, which is shown as, this is an open tray post. Now we have two kinds of impression post. One is called open tray post and one is called the closed tray post. These are all the examples of closed tray post. Open tray posts are more longer in size and it is of a cross shape. Now the next is lavatory analog, that what is going to do a replacement part for an implant on the lavatory. Then waxing sleeves are present to give the gingival collar. Prosthetic retaining screws, that if a prosthesis can be of two types. It can be either cement retained or it can be screw retained, or the new concept is cement screw retained prosthesis, CSRM. So in CSRP, then these are the prosthetic retaining screws that are present. Coming to implant supported overdentures. Now based on the support derived, the implant supported overdentures are also classified into soft tissue bone and implant bone, tooth bone and implant bone itself. That is, if it is getting a support from soft tissue and implant, if it is getting support from implant and the tooth, if it is getting support only from implant. Implant supported fixed partial denture, it can be implant supported fixed detachable bridges, it can be implant supported single tooth replacements. So these are examples of implant supported single tooth replacements, and these are examples of implant supported fixed removable type of prosthesis. Characteristic, it can be implant material, geometry and surface topology are different. Let's see what are the different implant materials that we can use. The most acceptable implant material which is biocompatible is commercially pure titanium and its alloy, CPTI, and titanium alloys. Then we have hydroxyapatite, of course, we have aluminum oxide, we have biogas, we have vitreous, carbon. Coming to implant geometry, what all different types of geometry can be there? So it can be screw, it can be cylinder based, it can be hollow baskets, it can be straight, tapered, conical, oval, trapezoid. The best is a tapering square type of implant. It's a combination of both. Now the implant geometry can also be depending on blade form, as I told earlier days. Plate form was their frame, subperiosteal, then there is supra or submucosal, and those are also called submucosal inserts. Those can be used in these days. This is mainly used for the implant supported overdenture. Those are called the submucosal insert overdentures. We have transmandibular, not used these days. Surface topography, that depends on how is the surface is gone. Is it isotrophic surface? Is it anisotrophic surface? An isotrophic surface is it is identical in all the sides. So it is iso means similar, and isotropic. That means when the surface is not similar from left, right, anterior, posterior with the directional pattern. So how all it can be? It can be acid blasted. It can be blasted, it can be sandblasted, acid etched, laser sintered. Those are called SLA, as sandblasted, acid etched and laser sintered implants. It can be porous, it can be oxidized, it can be titanium plasma spray, which is into again the newly come over implant topographically managed. Classification of the biomaterials that we can use for preparing an implant commercially. Now it can be metal or it can be its alloy, and I told you it can also be of ceramic, which is these days we have of aluminium or that of the zirconium oxide. With the biodegradable ceramics we have bioactive types of. Coming to the metal, we spoke earlier, like we have titanium and its alloy. Now titanium alloy is titanium 6 aluminium 4 vanadium Ti6Al 4Vs is the name of the alloy of the titanium. Also, it can also be of material cobalt chromium, it can be of iron, cobalt, nickel based alloys as well. Polymers and composites, yes, it was also introduced in the implant, that is polyethylene, polytetrafluoroethylene. We have silicon rubber, we have polysulfone, we have carbon, we have vitreous and pyrolytic carbons. We do even have carbon and carbon silicon coming over as a material of implant. Let's see the important part of Ti6Al4V, that is titanium and titanium alloy. Now the most important thing of titanium alloy is it's a biocompatible and it's an inert material. So safest of all materials. Now excellent resistance to corrosion it has. We know titanium is resistant to corrosion. And in absence of interfacial motion or any adverse environmental condition, this gets oxidized. Surface condition minimizes the biocorrosion phenomena. So the corrosion is not going to happen in these kind of implants. These are the original brain mark fixtures which you can see, the titanium screws used these days. This is the commercially pure titanium screw implants and the ones which we use these days. These are the implant kits. Various companies give up and come up with their own implant kit with various dimensions of implant, various width and length of the implant, and that has different screws. Like one company will have a length of the screw and the width of the screw similar to the drill that the company is giving in the implant kit. Surgical and prosthetic procedure for implant placement. Let's see your entire procedure starting from the stage 1. So in intraoral photographs we can see the missing area of the implant where we are planned to place. There's a overall OPG and diagnostic cast which is obtained. Then surgical guide is fabricated. Very important to fabricate a surgical guide. Two purposes it solves. One is the making of the OPG. At that time, if you have a surgical guide, you will exactly know where the placement is, and while placement also, it will also direct your drill in the exact position and you will not go wrong. So surgical procedure, the first step, you do an incision, reflection of the flap, we can see. Place the surgical guide and put the drill along with the surgical guide, the pilot drill. Then after placing the pilot drill, you put the depth gauge and you check the depth which is you have already reached. Take an IOP at that point of time on an RBG to find out the position of the implant that is placed. It is not important that at the first position should be straight. If you feel there is some modification, do the modification then and there itself. Everything gets osseointegrated with time. Surgical procedure, implants are placed now with a torque of not more than 25 micrometer. Then coming down, IOP with the depth gauge is checked. Surgical procedure is happening still. And we have placed 2 implants. We have covered it with the cover screw and the suture is placed, and these are the 2 implants post-operatively. Second stage of the implant is prosthetic phase. What you do, you reflect the flap back, you remove the cover screw and you put the healing abutment that I told. These healing abutments are put to create the gingival collar. So the gingival collar, based on the width of the tooth that is supposed to come, it will vary. Like in anteriors, it will require more bigger gingival collar than that of the premolars or mandibular lateral incisors. Suture is placed back and gingival former is placed. Then prosthetic procedure, healing at this stage at gingival formers, we can see after removal of the gingival former, you place the implant posts and you make the impression. There are 2 techniques of making impression. It is an open mouth technique. It is an open tray technique or a closed tray technique. This here which is used is the closed tray technique. So you have different kind of analogs for closed tray and open tray separately. These are the closed tray analogs present. Open tray analog will have a cross like this on the top with more serrations and wider serrations present. Then we come with the master cast is poured, and this is the lab analog or the implant lab analog present. These are the abutments that are supposed to be cut based on the interocclusal record as well as the space which we have, and then we are supposed to make the place the abutments in position. Now this is pink color is called the silicone, the gingival silicone, to reciprocate the gingival collar in the patient's mouth. Now you do the casting entirely, wax pattern metal tine bisque trial. Bisque trial is 1 step before the cementation, and glazing the thing, abutments are placed intraorally. Prosthesis is supposed to be placed. Very important thing here to note is a prosthesis is to be cemented only with a luting type of cement, that too temporary cement. Implant prosthesis, if it is a cement retained, is not supposed to be fixed with a permanent luting cement. So these are all the procedures, and that's how an implant is placed. And this is the newest technology which our missing teeth ought to have if it is indicated, and you need to always find out the proper indications and contraindications before going ahead for the proper prognosis and diagnosis of the implant.